Good afternoon. I'm Dr. Brian P. Johnson. I'm the Medical Director of the Joint Replacement Service at Mississippi Baptist Hospital. We're located in Jackson, Mississippi. We're a medium-sized community. We service a 3-state area, and our referral base extends over a 3 to 4 hour period or range. We are in my group, have 3 board-certified orthopedic surgeons who are fellowship trained in joint replacement surgery, and we do approximately 1,200 to 1,300 total joints a year. We initially partnered up with Marshall Steele in May or June of last year, and we launched our program in October of 2010. I'd like to talk briefly now about the joint replacement program's benchmarks and outcome analysis. Measuring and benchmarking our performance data enables us to manage our program. We utilize a joint-centered dashboard to accomplish this. One area we immediately identified as a significant opportunity was our rate of blood transfusions. Tracking and minimizing blood transfusions is important. Not only do they increase costs, but they can significantly increase the risk of infections. For most patients, transfusions are not necessary, but we never addressed this or looked at it seriously until we started analyzing our data. Before we started implementing our program, our transfusion rate was 43%. It's down as a group to 8% as of March of 2011, which amounts to a total reduction of 35%. My personal transfusion rate before implementing this program was in excess of 80% and is now down to less than 5%, and at our last tracking was at 2%. Collectively, as a group, we felt it was important to reduce our rate of transfusions. And we did this or accomplished this in 3 ways. The first way we decreased our rate of transfusion was by eliminating autologous blood donations. And this eliminated a tendency towards transfusing somebody with a higher hematocrit that really didn't need blood. In the same vein, the second thing that we did was we lowered our threshold for transfusions. We lowered it from a hematocrit of around 30 down to a hematocrit of 26 to 27. With the caveat that as long as the patient didn't have any underlying cardiovascular risk factors and at the time was not showing any cardiac compromise. The third way we reduced our transfusion rate, and probably one of the most important ways, was the use of tranexamic acid. Tranexamic acid is an antifibrinolytic, and it prevents the breakdown of fibrin and clot formation. By doing this, we significantly decreased our blood loss by about 20% and decreased our increased our postoperative hematocrit significantly. The combination of these three things have been paramount in reducing our overall transfusion rate. Because of the drastic reductions in transfusions, the cost savings were significant. Given that we are a high volume practice, we were able to reduce the number of transfusions by 270 transfusions in the past 9 months alone. We anticipate that our reduction will be even more significant in the next 12 months to come. In general, a transfusion costs approximately $1,500, and with this initiative in diminution of our transfusions, our overall savings have been in excess of $400,000, which represents an approximate 15% decrease in our direct costs. I'm happy to share with you at this point that we are nearing being the best practice in blood transfusion rates. I would suggest also that in your own practice that your blood management program can be a very important parameter in decreasing overall costs in joint replacement surgery and increasing reimbursement to your institution. I would also suggest that in developing your own blood management program that you consider the 3 parameters and the 3 benchmarks that we looked at to decrease our transfusion rates. Those being autologous blood programs, thresholds for transfusion, and the utilization of an antifibrinolytic agent like tranexamic acid.